Dr. Swati is the Assistant Professor of Gynaecological Oncology in the Department of Surgical Oncology at Jain Medical College and a consultant oncologist at KLE, Dr. Sampath Kumar Shivangi Cancer Hospital, Belgavi. She has been serving in her current academic and clinical roles since 1922. Uh, no, 2022, July. She is a recipient of DHR and ICMR Young Medical Faculty PhD Program 2024 to 25 grant for population-based project on high-risk HPV screening for cervical cancer in the 7 talukas of Belgavi district. She has won first prize for paper presentation Kasoga 2016 in our institution conducted, and first prize for poster presentation Kasoga 2015 for her research work. Over to you, Dr. Swati.
Yes, sir. Thank you very much, madam. A very good afternoon to everyone. I'm really pleasantly surprised to see 4 o'clock, the hall is full. I've never seen a CME where it is so full of people. So hats off to the organizers. I mean, you've done a really good job with so many registrations. And I would like to thank BLDE, all the organizers and SARS committee, and Asha Patil ma'am and Shailaja Bidri ma'am for giving me this opportunity to share the stage with such eminent speakers today. I hope me, Adarsh and Pradeep are able to do some justice to what has been presented so far. So I have completed I think everybody is aware of surgical oncology. I think gynec oncology is something which is not heard of, commonly in this region. So MCH Gynaecological Oncology is an upcoming subject, and I'm one of the second NEET SS batches for it in the country. So I've completed my MCH in Gynaecological Oncology from Amrita Institute of Medical Sciences, Kochi, and immediately post-graduation, I've joined KLE Cancer Hospital as a consultant gynec oncosurgeon. So I'm currently serving in Department of Surgical Oncology. So gynec oncology is focused not just on diagnostics and surgery, but also optimizing outcomes, focused on outcomes and the quality of life issues in gynecological oncology cases. So this is where I work. This is the KLE Cancer Hospital. Our president had come for the inauguration on January 3rd last year. So it's, this January, we celebrated our 1-year anniversary. This is Belgavi Department of OBGYN, Belgavi Institute of Medical Sciences. So Jain Medical College has a tie-up with the Belgavi Institute of Medical Sciences, where we provide OPD consultation services to BIMS across all specialties, super specialty departments, and oncology services as well. So we go there, see the OPD patients. If any patient requires intervention or anything, we get them back to KLE Cancer Hospital and treat them. What I would like to focus on is that North Karnataka and especially Belgavi is a resource-constrained region. So cancer, as such, is a bit expensive. Most of the patients that we get here are able to afford the treatment and everything because it is covered under scheme. So what I'm trying to highlight here is the in conjunction with Belgavi Institute of Medical Sciences, which is nothing but the district hospital of Belgavi. So what we're able to what we've been able to accomplish so far, despite all these limitations. So I would like to discuss, a couple of common case scenarios that we come across in our day-to-day practice and how their outcomes can be optimized across, starting from basics like diagnosing in terms of clinical workup, that is radiology and pathology. They're the cornerstone of oncology. Without them, I can't do my work. I mean, 70 to 80% of my work is in pre-operative diagnosis, and then we go ahead with surgery. So, I'll be discussing a couple of cases for endometrium ovary. So the first case, I'll be starting with carcinoma endometrium. So this is something which we are commonly seeing now. Young reproductive aged women being diagnosed with carcinoma endometrium. So a 35-year-old, so bear in mind all of these cases, most of them I've got from BIMS, District Hospital. So a 35-year-old nulliparous case of secondary infertility with heavy menstrual bleeding for 3 months. 2 endometrial biopsies reported. Now again, this was reported as complex endometrial hyperplasia with atypia. Now others will comment on the terminology because this is not the correct terminology as of now. Then always, I would always ask all the clinicians to please do a radiological workup before you do any intervention like biopsy or DNC. Because once you do biopsy or DNC, it causes artifact distortion, especially when you're trying to read myometrial invasion or any abnormality invading into the junctional zone. So especially if you're working up a case of postmenopausal bleeding or abnormal uterine bleeding, always do a radiological investigation, at least a screening ultrasound first. Don't go in for a high-end investigations like MRI, but look, at least get a baseline screening MRI ultrasound done, and then go in for any intervention on the endometrium, because that causes artifact distortion. So I'll ask Dr. Pradeep to highlight the radiological features in this case.
So, thank you, Dr. Swati. This particular case was referred for MRI pelvis for valuation of endometrium and to rule out the endometrial carcinoma. So, basically, on evaluating endometrial study on MRI, we basically, as a part of checklist, look into the tumor size, and how much is it invading the invasiveness of the tumor into the myometrium, whether is there an invasion or is it less than 50% or more than 50%? Is it involving the adjacent structures? Is it involving the urinary bladder wall, the rectum? Is there any lymph nodes? These are the few things we generally focus while reading a MRI image for endometrial valuation. So in this case, typically the helpful sequences for endometrial valuation would be the T2 weighted sequences, the STIR sequences, and another helpful is diffusion weighted imaging, and then the contrast imaging. So here is a image of T2 weighted study where it is showing showing hypointense as compared to the bladder intensity. So typically the endometrium appears less intense than usual when it is involved. So it is not so bright, but it is hypointense. And then we can see there is an invasion of the junctional zone, which is usually T2 hypointense. And then we can see that there is some extension into the myometrial tissue. So assessing the extent of myometrial invasion, an imaginary line can be drawn to the inner margin of the myometrium, and then a perpendicular line from there touching to the serosal level, which gives the thickness of the myometrium, and then the extent of the invasion. The ratio of that will give us the value, whether if it is more than 50% or it is less than 50%. So in this case, it seemed to be less than 50%. And further on diffusion, the lesion showed restriction, and where it is appearing typically bright on diffusion, and further on ADC correlation, the lesion appeared showed signal loss. So there was mild signal loss, giving the diagnosis probably it is a malignant lesion. Further on screening, there were no lymph nodes or any omental involvement.
Thank you, Pradeep. So we did an office endometrial biopsy at our hospital, and the report was endometrioid adenocarcinoma grade 1. Because it is already a proven case of carcinoma endometrium, it is useful, especially in case of serous or type 2 cancers, what was earlier known as type 2 cancers, that we do CA-125 even for monitoring purposes, for prognostication. So CA-125 and LDH levels were normal. We always do a preoperative molecular prognosis or molecular classification on the preoperative endometrial biopsy. So we have the molecular classification for endometrial carcinoma, which is nothing but poly mutated, and MMR deficient, that is mismatch repair deficient, and then P53 abnormal. If it is none of these mutations are present in the tumor tissue, then we go ahead and label it as non-specific molecular profiles, that is nothing but NSMP. So the stepwise is in a cost-effective manner. First, we would like to do P53 by IHC. If P53 is wild type, or if it is abnormal, then you classify it as P53 abnormal. If it is wild type, then we can go ahead and get poly mutation done, or you can do a MMR by IHC. So if that again is negative, so then you can go ahead and do a poly. So right now, cost-effectively, P53 first, followed by MMR, followed by poly, because poly has to be done by next generation sequencing. So KLE Cancer Hospital has a tie-up with MedGenome where we get this thing, all of these genes in one panel that is called as molecular prognostication for endometrial cancer panel. So we look at MLH1, MSH2, MSH6, PMS2 for mismatch repair efficiency, and POLY for POLY mutation and P53 abnormality. So now in this case, she's a 35-year-old nulliparous woman with secondary infertility. Her preoperative MRI showed less than 50% mymetal invasion. This case is a multiple classifier of POLY and P53. In POLY and P53, it is a multiple classifier. We'll always go ahead with POLY. Now, why should we do molecular classification? So this is called as PROMIS classification. So PROMIS is nothing but proactive molecular risk classifier in carcinoma endometrium. So traditional histopathological criteria, as madam would agree, are incomplete surrogates to understand tumor biology or tumor behavior, because there are a lot of indolent tumors that have excellent outcomes, and you have aggressive tumors which have very low risk criteria as per standard histopathology, but it is not reflective of the tumor biology per se. So along with this, it is also can also be used for targeted or immune therapy. So MMR deficient can also be used where, so they have targeted therapy where you have immune checkpoint inhibitors. So specific to that mutation, we can deliver the chemotherapy drugs, and the response to them is much more favorable than traditional drugs which have already been employed earlier. So this goes in favor of precision medicine. So there are different reasons why we do molecular prognostication for endometrial cancer, and this is a PROMIS classification that we do. So she's a multiple classifier, but here we'll go with POLY. So we did the staging surgery for her. So I'm sure, how many OBG postgraduates are here? So have you heard of sentinel lymph node biopsy and carcinoma endometrium? Just as a, oh, these are all first year or second year, ma'am? Think too early. Okay. So sentinel lymph node is nothing but the first lymph node which receives a lymphatic drainage from the primary tumor. Okay. So if you have a basin, like for example, the right pelvic side wall with the external iliac lymph nodes, internal iliac lymph nodes, common iliac, and then obturator node. So the first lymph node which receives the lymphatic drainage from the primary tumor is called the sentinel lymph node. If you pick up that lymph node via dye, where there are various dyes which you inject into the primary tumor, and then if the dye drains into that, whatever lymph node the dye drains into for the first time, the first pickup. So that is a sentinel lymph node. If you are able to excise that, it is sort of, if you've proved sentinel lymph node mapping and biopsy in that particular organ with that particular cancer, then it is sort of that lymph node is representative of the entire basin. So you don't need to remove additional lymph nodes here. The advantage with sentinel lymph node mapping and biopsy is that you avoid any unnecessary morbidity. Immediate morbidity would be postoperative complications in terms of neurovascular complications intraoperatively and blood loss and all that. But overall, now we are focusing on quality of life. So lymphedema was a major concern when it came to bilateral pelvic lymph node dissection and para-aortic lymph node dissection in endometrial and cervical cancer, which is why we're trying to eliminate radical surgeries, and we're trying to validate sentinel lymph node mapping. So that avoids bilateral chronic lymphedema for patients with carcinoma endometrium. So we are validating this protocol now. It does require thorough validation, and we have started the validation now. So it does require thorough validation and false negative rates to be low. So we have the Striker 1788 platform, which has the endoscopic near infrared visualization mode that helps to pick up the ICG. So indocyanine dye is the method or the dye that is preferred for sentinel lymph node mapping and biopsy in carcinoma endometrium with a false negative, very, very low false negative rates. So here is an example. This is a case, one of the cases that we have done. So here you can see. So this is the cervix here. We've injected the dye at 3 and 9 o'clock position in different concentrations. So there's a protocol. So we follow the Memorial Sloan Kettering Cancer Center protocol for algorithm for sentinel lymph node mapping and biopsy in endometrial cancer. So we've injected the dye into the cervix. So this is a primary tumor site. And then now you can see sort of a slight afferent going up to the lymph node here. So that is the first sentinel lymph node, which is nothing but the external iliac lymph node. This is the external iliac lymph node. So here you can't see an afferent per se. You don't see a afferent pathway per se from the primary cycle, but this node is completely well lit up. So even in the absence of an afferent pathway, you can still call it as a sentinel lymph node. So this is a secondary draining lymph node, which is nothing but the obturator node. So we have this for laparoscopic. We also have the SSI mantra for robotic surgery, which is a second generation. So we're able to do minimal invasive surgeries for endometrial cancer patients here. So this is the console where the surgeon sits and operates here. So it's literally like driving a manual car. I don't know how much of the current generation knows about driving a manual car now that everybody's driving EV and automatic cars, but it's very much like driving a manual car. So these are the arms of the robo. This is a patient card which gets docked onto the patient, and these are the arms here. So whatever movements are being done here at this level gets replicated there. So we have the we have the SSI mantra for robotic surgery. So she's undergone staging surgery at Cancer Hospital. I'd like Dr. Adarsh to please elaborate on the histopathological features here.
As you can see in this photomicrograph that this is the endometrial glands and this is the myometrium. You can see that the endometrial glands are very prolific and they are showing invasion into the myometrium. So this says that it is malignancy. So here we have to distinguish between endometrial hyperplasia without atypia and with atypia. So the current terminology is used by FIGO is endometrial hyperplasia without atypia and the other one is endometrial hyperplasia with atypia. So you can see here that these are the glands which are there, which are more as compared to the stroma, and they don't show any atypia. Here in this photomicrograph, you can see that these are the endometrial glands which are showing gland-in-gland formation, and also they are showing atypical lining. So this is endometrial hyperplasia with atypia. And this is our histopathology report.
So that was the first case, a 35-year-old nulliparous reproductive age woman with carcinoma endometrium with myometrial invasion. So myometrial invasion again is a contraindication for medical management of endometrial cancer, and here definitely surgery would be advised in this case. So case B is again another common scenario of 52-year-old multiparous woman with endometrial biopsy done outside reporting endometrial hyperplasia with atypia. She went ahead and got a hysterectomy done outside. Final histopathology was endometrioid adenocarcinoma. So slide and block review at a hospital confirmed the same. Here the problem is, this is I think one of the common scenarios that most of the gynecologists also come across here. In Belgaum we have come across this, where the patient undergoes surgery for say a Pippel's biopsy outside, and then the final histopathology comes as endometrioid adenocarcinoma. So endometrial hyperplasia with atypia always harbors the risk of carrying concurrent endometrial carcinoma of around 5 to 10%. That risk is always there because carcinoma endometrium is notorious for intratumor heterogeneity. So you have to make sure that you either do a hysteroscopic guided endometrial biopsy where you have complete resection of the endometrium, or you have to do a thorough DNC so that you don't miss any foci. So if you end up doing an office endometrial biopsy or something, you might end up missing a foci somewhere else, because that is what happens in case of endometrial carcinoma, as madam would agree. So 5 to 10%, so atypical endometrial hyperplasia has 5 to 10% risk of carcinoma endometrium. So in this case, the lymph nodes were not addressed. So post-op, her CA125 and LDH was normal, baseline MRI was normal. One of the most common dilemmas again for a radiologist as well as a pathologist is differentiation between myometrial invasion and adenomyosis. So Adarsh?
Yeah, so here you can see on the right hand side that these are the neoplastic endometrial glands, and there is infiltration over here. You can see this one gland which is infiltrated into the myometrium. So there is infiltration of these endometrial glands into the myometrium. The left photomicrograph shows there is these well-formed glands, okay, and there is stroma also. So as you can see, because of the stroma and the glands, this is more of adenomyosis as compared to the invasion by the tumor. So as per the guidelines as of today, adenomyosis cannot be considered as malignancy or invasion in cases of endometrial malignancies. So this has to be reported separately because a lot of studies are still going on to address whether there is any genetic abnormality seen over here in the adenomyotic patch, or whether it is an true extension of the tumor itself. So for as of now, you have to report adenomyosis in endometrial carcinoma case if you find any.
I'd like Pradeep to please talk about some of the features and adenomyosis and mechanical invasion.
So this was a case which was under the case. She was undergoing IVF treatment, and during the treatment she had hyperplasia, and then multiple DNC she underwent, and further she also underwent the histopath study where some TPS cells were reported, and further MRI was asked for to characterize whether it is having any malignant features or it is just hyperplasia. So again, evaluating T288 sequences, here the image shows widening of this anterior myometrium. And as you see, there is irregularity in the junctional zone. There is also the endometrial intensity is seen as a linear spaces, hyperintense cystic spaces within the myometrium and the widened junctional zone. So, and this irregularity is also attributed to the multiple dilatation and curettage the patient underwent. Further, on diffusion evaluation, there seemed no restriction. Even on B1500 value, there was no restriction. What was seen as there was no reversal on ADC mapping. So it looked more of benign and no characters of malignancy. Further, a contrast study was done where a dynamic contrast study did not show any such enhanced enhancement or any hypo. It was negative for it. And post-contrast images showed uniform enhancement. Even the cystic spaces which were seen in the myometrium showed similar intensity what was seen with the endometrium. And during the T2 evaluation, the endometrium also showed no reduced intensity within the endometrial cavity. So with these endometrial tissue like linear cystic spaces within the myometrium, we came to conclusion that it is probably adenomyosis.
This is the final histopathology. So we got ahead and did this molecular classification for the unoperated, the unstaged case. So unstaged in the sense because here the pelvic lymph nodes are not addressed and it's a case of carcinoma endometrium. It turned out to be P53 wild type. Look at the variant allele frequency rate, it's 1.39%. So anything, it is below the level of significant detection. So that is why we will take it as wild type. So it is not significant. It comes into NSMP profile. NSMP profile comes into low observation category. So I'll talk about the prognostication of all the cases at the end. This is another common scenario which we see a 75-year-old lady with postmenopausal bleeding with intermittent spotting for 4 months prior to presentation. So another thing which is most commonly seen in our area is women usually don't come to the OPD early. So postmenopausal bleeding, even a spotting, they think a spotting is not a significant enough complaint only unless they start bleeding heavily with passage of clots and changing pads, or there's a lot of significant discomfort. They wait until then and then they come. So we went ahead and did an office endometrial biopsy for her. So radiological features in this case are nothing but 50% myometrial invasion with no other significant pathology on the radiology. We did a molecular prognostication for her and it turned out to be mismatch repair deficiency with MMR deficient. So one other important thing about molecular prognostication is if it comes as P53 abnormal, then peritoneal staging preoperatively, it helps you to decide. Peritoneal staging is nothing but infracholicomentectomy, peritoneal biopsies from bilateral paracolic gutters, bilateral hypochondrium, fluid, and pelvic. You have to seriously consider the pelvic lymph node and para-aortic lymphadenectomy in these cases because these tumors behave aggressively. That is nothing but serous, clear cell, and P53 abnormal tumors. So they end up needing adjuvant chemoradiation even after surgery. So staging surgery has to be complete first and then followed by chemoradiation. So doing a molecular prognostication upfront also helps you decide the radicality of surgery here. So she underwent staging surgery, and these are the histopathological. I asked Adarsh, yeah.
So these are the photomicrographs of the case in discussion. So you can see that these are the, again, neoplastic glands of the endometrium, and there's infiltration of the endometrium into the myometrium. And here you can see that there are few areas which are solid areas. We will show it to you. And you can look at this photomicrograph as a comparison for giving grade 1 and grade 2. So in grade 1, you're seeing a lot of well-formed glands. So the FIGO classification says that if the gland formation, the solid formation is less than 5%, then it is grade 1. If the solid tumor is seen in the range of 6 to 75%, it is grade 2. And if you see more than 75% solid tumor, then it is grade 3.
This is great.
So here you can see that in this photomicrograph, these are the few areas which are showing the solid component of the tumor. And in this slide, they were amounting to around 6 to 8%. So we had classified it as grade 2 endometrioid adenocarcinoma.
So this was the final histopathology. So case D is 56-year-old again with postmenopausal bleeding, 2 episodes with minimal spotting. So she underwent DNC at OBGYN at BIMS again, endometrioid adenocarcinoma, sliding block review at a hospital confirmed the same. We got and did a molecular prognostication. It turned out to be T53, again wild type. Post-staging surgery, histopathological features.
Yeah, this is a photomicrograph where you can see the entire endometrium and the myometrium. So you can see that the endometrial tumor has infiltrated more than half of the myometrial thickness. So the myometrium actually starts from over here approximately, but here you can see that the tumor has infiltrated more than half of the entire myometrial thickness. So this is T1B, where the endometrial tumor has infiltrated more than 50% of the myometrial thickness. Here you can see that this is again the tumor invasion which is seen. Okay, and there are solid areas over here. So that is why it was classified as grade 2. This is another photomicrograph where you can see that the solid component is approximately around 10% of this field. So because of that, we have called it as grade 2. This case, we had done ER, PR, and P53.
Because
So
on molecular prognostication, we got TP53 1.35% as a VAF rate. So this is again below the level of significant detection. So this classifies as TP53 wild type, and with no other mutations present here, this becomes a non-specific molecular profile or NSMP profile. So in an NSMP profile, we always do a ERPR, estrogen receptor and progesterone receptor positivity to look again. So ERPR positive has a better prognosis compared to ERPR negative.
So here you can see that there is extensive positivity of the ER.
This is on IHC,
This is
immunohistochemistry.
IHC. So you can see that there are this nuclei which are strongly positive for ER, as opposed to this which is negative ER case. The similar with the PR, you can see that the nuclear expression of progesterone receptor is quite strong, and the similar one is negative over here, just for comparison. Then we did P53. So this P53, you can see that few of the cells are showing positivity, but it is not that intense. So this is a wild type. This was our case. And this is the one which we call it as P53 mutant, where there is strong and diffuse expression of P53 in the nuclei of the tumor cells. And this photomicrograph is showing no expression. So this is null. So P53 is expressed as in 3 groups. That is null, wild type, and mutant type. So mutant type requires should be addressed because it definitely says that it is malignant. If it is wild type, then you have to take into consideration the NGS panel for P53 expression, and then based on that, the further call will be taken.
This is the final histopathology. So 81-year-old, again with postmenopausal bleeding, endometrioid adenocarcinoma grade 2. Preoperatively, serosal breach was reported, and I'd like Pradeep to please talk about the features here.
Yeah. So here is a T2-weighted imaging again, which is showing which titulated imaging, is also showing extensive widening of the endometrial cavity. And there was further thinning of the endometrium in the fundal portion anteriorly, where there was suspicious breach around this region, where even the small bowel loop is seen adherent to it. For the lesion further showed contrast, the diffusion restriction. And on contrast imaging, the breach was seen here where the adherence. Sorry.
So we did the, till Pradeep's images load up, so we did the molecular prognostication in this case, and it turned out to be NSMP, that is non-specific molecular profile, and it was ER-PR negative. Because serosal breach was already reported preoperatively, and an NSMP profile with ER-PR negative, we went ahead and did a full peritoneal staging here. So,
Coming to the on contrast, the invasion was confirmed where the enhancing lesion is seen to extend beyond the serosal region and seem to be involving the adjacent bowel loop, which is adherent to the uterus. And there are also seen few iliac lymph nodes, suspicious lymph nodes. And on abdominal screening, there was no peritoneal involvement.
yeah.
Over to you, sir.
Thank you. So, Adarsh, would you like to comment on the histopathology here?
Yeah, so as you can see that this photomicrograph shows the tumor cells, and you can see there's no myometrium as you could see in the previous cases. So the tumor has completely infiltrated the entire myometrium and has come over here. This is the serosal lining of the endometrium. So in the higher power view, sorry. So in the higher power view, you can see that this is the serosal layer of the uterus, and the tumor is infiltrating completely into the serosa of the uterus. So in this, we will also look in for lymphovascular invasion. So you can see this lymphovascular space invasion. These are the tumor cells which are seen in the lymphatic channels as well as in the vessels. So, and here also you can see there are around 2 vessels over here, but here you can see close to around 4 or 5 vessels which are showing tumor emboli. So this suggests that there is lymphovascular space invasion. This has to be commented upon, and you have to comment whether there is extensive, focal or no. So focal is when you see less than 5 lymphovascular spaces invaded by tumor in a slide. And if you see more than 5 vascular spaces being invaded by the tumor in a single slide, then it is called as extensive. And if you don't see any, then it is called as no lymphovascular space invasion. And this case had extensive lymphovascular space invasion in this. So also this case had got nodal metastasis. So you can see that this is a photomicrograph showing the lymph node of the case, which is showing reactive lymph nodes over here. And then you can see these tumor cells which have infiltrated the node. So in comparison, this is the normal lymph node structure, which shows this germinal centers and follicle. Further, the same section in continuation had got tumor extending into the extranodal fat. So this we call it as extranodal extension of the tumor into the adjacent fat. This was a final HPR. And also this deposit also was sent to us for the final histopathology. But however, there was only just granulation tissue. There was no tumor deposit seen in this case.
So this is another case scenario which we come across, that despite adequate preoperative counseling, that surgery is not the treatment, is not the only treatment for your current condition. Most of the patients harbor the delusion that if you operate and you remove the disease, then they don't have to take any further treatment, and that is the complete treatment that is required. So that is one of the most common misconception here. But we have repeatedly always do this. This is the first step that we do, that we, like, when we counsel the patients for surgery, first we always advise them that if after the surgery, once the final histopathology report is obtained, you have to go ahead and complete, if your adjuvant chemoradiation is required or adjuvant radiation treatment is required, until you finish that course, your treatment is not complete. So even if you have undergone surgery, if you don't take the chemoradiation, you're probably going to have a recurrence here again. So this is a 65-year-old lady with postmenopausal spotting. Again, became embarrassing. She came for us for consultation. She was also unwilling for any preoperative biopsy and wanted to go for surgery directly. So this case, we went ahead and did a frozen and proceed. So we have frozen facilities available there. So we did a staging laparotomy. We did after the on the frozen section, it was confirmed to be as endometrioid adenocarcinoma grade 3. So we went ahead and did grade 3 with extensive areas of necrosis. So extensive areas of necrosis, there's always a high suspicion of a P53 abnormality here. So we went ahead and did a complete peritoneal staging in this case as well. So Adarsh?
As you can see here in this photomicrograph, you can see just sheets of tumor cells and in the myometrium. And in the next photomicrograph, this is a higher magnification where you're seeing this sheets of tumor cells. As compared to the first case which we had, which was grade 1, you're not seeing any tubule formation. So that is why it was graded as FIGO grade 3. And you can see here all this pink structure is the extensive necrosis, and just around the vessels, you can see the tumor cells are still viable. And this case was showing focal LVSI. You can see these two vessels which are showing tumor emboli. So this was showing focal LVSI. And the tumor was infiltrating more than 50% of the myometrium. So this was the final histopathology report.
So in this case, on the final histopathology specimen, we got the NGS done, but NGS should ideally be done on the preoperative, your endometrial curettage or the DNC material. So this definitely again showed TP53 mutation on NGS. This is a 72-year-old lady again with postmenopausal bleeding, which is the most common complaint. DNC HPR reported as serous carcinoma. So this will obviously be reflective in their TP53 levels. So TP53 is common in serous carcinoma. So you can see the variant allele frequency rate is 33.49%, which is quite high. We went ahead. So here in serous carcinoma, again, you have to do peritoneal staging of infracolic omentectomy, peritoneal staging, and biopsy. These are the histopathological features. Yeah, this is serous.
Yeah. So here you can see that this is the endometrial lining, and the tumor is arising from here. And you can see that there are these papillae which are there, and these papillae are showing pleomorphic cells which are showing hobnailing. And here you can see that there is lymphovascular space invasion over here. And this was our final histopathology report, which said that there was uterine serous carcinoma and it was infiltrating more than half of the myometrial thickness.
Lymph nodes are free, and omentum is free.
Yeah, omentum is free and the lymph nodes are free.
Yeah. So this is another type 2 case of CA endometrium. This is a 60-year-old lady with complaints of postmenopausal spotting again. Endometrioid adenocarcinoma on biopsy, and NGS testing showed TP53 abnormality. What is unique to this case, I'd request Dr. Pradeep to please talk about this case.
This was a case referred for MRI. Here, T2 star sagittal image shows two foci of involvement where the lesion is hyperintense on T2 star, involved in the lower segment and involved in the upper segment. There is more than 50% breach of the, invasion of the myometrium. And further, it is also extending into the endocervical canal. There is also seen suspicious a cervical stroma invasion along the posterior cervical lip. Further, there were metastatic lymph nodes seen, and the lesion showed diffusion restriction. There were metastatic lymph nodes, pelvic lymph nodes seen.
Thank you. So this is the case of CA endometrium with extension into the endocervix. So she will require type C1 radical hysterectomy and rest of the staging surgery for carcinoma endometrium. So these are the histopathological features for endocervical. Yeah.
Yeah, this case, it was endometrial adenocarcinoma grade 2, and you can see that the tumor is here and it is infiltrating. These are the endocervical glands. And this is a part of ectocervix which is seen. So the tumor is infiltrating into the endocervical glands. So that is what we wanted to demonstrate over here. And this is a photomicrograph which is showing tumor metastasis into the lymph node. There are these two foci which are showing metastasis. This was the final HPR.
So we have the current FIGO 2020-23 staging for carcinoma endometrium. It is a surgical-pathological staging. And we have the ESCO, ESTO, ESP guidelines for management of endometrial cancer, which is updated in 2025. Molecular, I've already reasoned out as to why molecular classification is important for this case. So these are the different risk groups. So here you can see the prognostication risk-based criteria on earlier criteria what we had, and these are the current criteria what we have. So there is definitely, for example, in case C, earlier it would have been just high intermediate, and then now it has jumped up to high on account of P53 abnormality, and here she will require adjuvant chemoradiation rather than just adjuvant radiation. So similarly, even in the last case with endocervical extension, even though she would have been earlier classified as high intermediate as per the earlier risk criteria in 2016, but now because of P53 abnormality, she jumps up, or there's escalation of treatment to adjuvant chemoradiation plus BBT. So there's escalation of treatment in order to address the tumor biology directly, so which we are able to know on account of the on account of the testing that we have done. So in the earlier case, if you look at this, the 35-year-old nulliparous woman. So here, if it is multiple classifier, in the sense there's poly and TP53 mutation. So if we had just done a P53 IHC and it had come positive, then she would have gone into high risk criteria. But now that we have poly, we can definitely go ahead and say, based on evidence, that poly has a much better prognosis, and always it is a genomic driver, and P53 mutation here will be secondary. So we'll consider poly, and poly always has very excellent prognosis, so we'll just keep her on observation. She will not require any adjuvant chemoradiation. That's why molecular prognostication is very important in endometrial carcinoma. So we have fantastic radiation oncology team, and a medical oncologist, Dr. Rohan Bisse, and Dr. Sapna is a radiation oncologist. We have TrueBeam, which is a high versatility LINAC, and Halcyon Elite as well. So adjuvant radiation in postoperative patients we deliver through VMAT technique, that is volumetry modulated arc therapy. So here you can see the green part. So this is, we are covering the pelvic basin, which normally contains the pelvic lymph node, so we can cover the LVSI and any lymph node metastasis or anything here. The yellow part, what we see is the vault region, which is a target region which is being delivered here, along with the pelvic basin. So because of VMAT therapy, we are able to deliver almost precision dose to the target areas of the pelvic basin and the vault region by sparing the vital organs like bladder, rectum, and the femoral heads. So these are the things which we have here. It is irrespective of whether the patient is under scheme or whether the patient is self-paying. So the same treatment planning and treatment and the facilities is being given to a scheme patient or a self-paying patient here. So this is the case of carcinoma endometrium. Next, we have the most common complex scenario, which is a 30-year or reproductive age woman who's coming up with us with a complex ovarian mass, a solid cystic ovarian mass. So this is a common scenario which we come across in our day-to-day practice, and this has important fertility implications for a young woman who's planning for fertility and just 5-10 minutes, who's planning to conceive, and like she has a solid cystic ovarian mass. So
So evaluation of ovarian lesion on MRI. Here is a T2-weighted sagittal image, which is showing a large multi-septated lesion, which is growing beyond the pelvic brim into the abdominal cavity, causing mass effect and displacements. There is also seen these solid areas which are slightly T2 dark. Multiple such solid areas seen within the this cystic portion of the lesion, and further these further on diffusion weighted imaging, the solid portions showed mild restriction. Uh, However, uh, on contrast imaging, post contrast images showed showed lesser enhancement of the solid portion as compared to the myometrium. So, so based on this, again, it was characterized as ORADS 4, which is of intermediate risk.
So yeah, go ahead.
Yeah. So ORADS is ovarian adnexal reporting and data system, where it category of malignant to a category percentage, or so it is classified from 0 to 5, where it is incomplete evaluation. One is with low risk less than 5%, and over present region fits into already of 90%. It is as similar as 4, but the solid portions in such lesions are T2 dark, show extensive restriction, and show better enhancement as compared to the myometrial tissue, and also show high risk intensity on uh, dynamic contrast imaging. So why MRI is a choice over CECT? It gives better characterization of intraregional content. Uh, like when we can easily characterize between serous, mucinous, and endometrioid cysts, which is difficult with CECT. And with sequences like diffusion weighted imaging and ADC, we can it helps in characterizing benign versus malignant. And the dynamic contrast imaging also helps with time gated mapping, helps to characterize the malignant versus the benign lesions, and also is helpful in salvageable ovary in fertility sparing surgeries.
So she underwent completion staging surgery. So these are this is a case of mucinous histidinoma. I'll just skip forward to this. The most important part is that borderline ovarian tumors is an upcoming entity, especially in reproductive age women. So fertility sparing staging surgery can be done here. And for postmenopausal women, we recommend complete staging surgery. So when you're doing complete staging surgery, especially in a reproductive age woman, problems with relation to menopause are also a concern. This is a 38-year-old woman. So with the mucinous borderline ovarian tumor, in order to avoid the effects of menopause pre-early, like iatrogenic this thing menopause early on. So we've started her with estrogen valerate. So estrogen valerate, and she's continuing to do well at 38-year-old. That is not a contraindication in case of borderline ovarian tumors. And in case of borderline ovarian tumors in a reproductive age woman, we can just do a unilateral salpingo-oophorectomy and peritoneal staging with infracholecommentectomy and biopsies. So the third case is a solid ovarian mass in a reproductive age group, which is 28-year-old. It was a case of LDH showed raised tumor values on preoperative evaluation. She underwent a fertility sparing staging surgery with right salpingo-oophorectomy and infracholecommentectomy. Uterus on the other side, ovary and left ovary was spared. These are the histopathological images, and this is the IHC confirming CD117 positivity with PLPA positive, suggestive of dysgerminoma. So the most unique part of this, after disease-free recurrence of almost 2.6 years, when we did a AMH level evaluation for her. So it showed low AMH levels for her age. For her age, a 20-year-old unmarried woman who's undergone a fertility sparing staging surgery with low AMH levels is a concern. So that is why we went ahead and advised her to undergo oocyte preservation at her age, because the most common thing otherwise would be for her to get married as fast as possible, and that is a general advice which is given. So we don't do that anymore. Women can lead their lives however they want. So we advised her for oocyte cryopreservation. So 1.5 years post DFS, disease-free survival, she's undergone oocyte preservation, she's continuing to pursue her BCA studies. She's completely fine. So that is one thing which we are able to do even in a resource constrained setting. So these are some of the things which we are able to implement in gynecological oncology in our region. The other thing which I wanted to highlight was this is the Department of Health Research ICMR Young Medical Faculty Program. JNMC is one of the colleges to have gotten this program. So we are doing a community-based primary HPV-based testing for cervical cancer, focusing on HIV positive women, because HIV positive women are 5 to 6 times have a higher risk compared to that of general population to develop cervical cancer with higher rates of HPV, and HIV and HPV co-facilitate each other. So this is one of the projects which we are doing with a sample size of 1800. KLE has also started a KLE HPV vaccination initiative targeting girls, age-appropriate girls between 9 to 14 years. That is, we have gone with the implementation strategy of sensitizing all the school girls across all KLE societies, English medium schools. We have targeted them regarding the need for vaccination against cervical cancer, educated their parents, gotten their consent, and administered the vaccine. And so far, we've been able to do that for 600 girls across all the KLE society schools in Dharwad, Hubli, and Belgaum district. So these are some of the things which we are able to do. I mean, at least I was able to do in the few years that I've joined as a gynecological oncologist. So thank you very much for your prime and patient hearing. Thank you.
Thank you, Swati. Thank you, Dr. Swati, for more informative and more elaborated discussion on case presentation. But I would like to ask one question. Basic gynecologists who are handling with the postmenopausal patients,
Yes, ma'am.
whether a basic to get it done MRI before going for a diagnostic DNC.
Ma'am, that's what, if
Because we
it's
want to treat further also here has a first stage.
Ma'am, yeah, a woman comes to you for postmenopausal bleeding, get a screening ultrasound done just to know if there's any actual gross lesion which is present in this in the endometrium. If you see a polypoidal lesion or a thickened endometrium or suspicious features on the TVS itself or the ultrasound itself, then you can go ahead and get a MRI done. But we usually follow that protocol there, where postmenopausal women high risk, we get a MRI done, ma'am, there.
No, we want to know when to refer to oncologist.
Get a preoperative MRI. You can go ahead and do a DNC, ma'am. Once the DNC shows either endometrial hyperplasia with atypia, because here we'll have to do a sentinel lymph node biopsy here. I mean, there's a role of sentinel lymph node biopsy even in endometrial hyperplasia with atypia. So for endometrial hyperplasia with atypia and endometrial carcinoma onwards, you can refer it to a gynec-oncologist or surgical
Whether to go for
oncologist.
hysterectomy, total hysterectomy.
Sorry, ma'am?
Hysterectomy. Whether we can do or you have to refer.
Ma'am, that's what there is a role for. There is a role for sentinel lymph node. We always, as a gynec-oncologist, back then even in Amrita, so the gynecologists were doing the DNC. If it was atypical endometrial hyperplasia, they were doing a baseline P53. If that was, again, because there's a role for P53 positivity even in atypical endometrial hyperplasia. So atypical endometrial hyperplasia was generally referred to us. So we used to do a sentinel there also.
Whether to go with the hysteroscopy.
Hysteroscopy and guided endometrial biopsy, yes, is the first choice, ma'am. If it is not available, then DNC also is good enough. A thorough DNC of all the 4 walls, procedure-wise, is also good enough. Because in resource-limited settings like BIMS, for example, Belagavi Institute of Medical Sciences, they don't have a hysteroscopy set. So they make sure that they get adequate, thorough curettage material through DNC itself.
Okay. Thank you.
I'm Dr. Savitri, ma'am. I'm a pathologist.
Hello,
It was
ma'am.
good
Yeah.
presentation, ma'am.
Thank
Actually, I want to ask one question. Like sometimes we'll give it as endometrial hyperplasia without TPA.
Yes,
so
ma'am.
how will you proceed for that, ma'am? Endometrial
So that is a benign case that a
benign,
gynecologist
so
can handle. Yeah.
So no need to do anything.
No,
like.
no, no.
And
That is
sometimes,
not a case
what
for
happens,
us.
we get the endometrial biopsy in the fragments. So
Yeah.
we will see few atypical cells, then we will advise them like repeat biopsy. So
Yeah,
like,
that you can definitely go ahead. If you're not sure of the adequate or the adequacy of the specimen that you've received, then you can ask for a repeat biopsy. Yeah. Adarsh also does that, no? Adarsh, yeah. So far, because we've been trained in some of the procedures, like Pippel's endometrial biopsy, not everybody is confident. Not everybody knows how to like do the procedure. So if a beginner or like somebody who's not experienced starts doing that, there's very high chances that you're not curating the entirety of the uterus there. So you're likely to miss a foci somewhere in the endometrium.
That's
So
what, ma'am,
yeah.
we are concerned about. Like many times we'll see atypical cells, but we'll not be able to tell whether like frank malignancy, like borderline cases.
I think
So that
Adarsh
time,
can address that. Yeah.
Yeah, no, ma'am, there's nothing to worry. The thing is that we pathologists shouldn't be scared to ask for a repeat biopsy because based on this reporting only, the entire line of treatment of the or the management of the patient is being decided. So we all are here for with only one motive to address the patient in a more adequate manner. So proper interaction with the clinician and asking them the radiological findings, discussing it with the radiologist, whether what the radiologist feels about it, and then coming to a conclusive diagnosis makes more sense rather than just all of us working independently.
No,
We
we are
working
doing
as a
that, sir.
team
Huh.
will definitely help the patient in a much better way. So in our center, I don't hesitate to talk to the clinician and tell them or ask them for a repeat biopsy.
Yes, we
So
are also doing like that.
yes,
Only,
ma'am,
we'll
that
give
is the best
huh.
practice which we are following, and that I think should be followed globally.
Thank you, sir.
Endometrial hyperplasia, ma'am, normal endometrial hyperplasia is a gynecologist. So half my job at BIMS is screening cases. If it is ORADS 3 on MRI evaluation of any ovarian masses, or if it is endometrial hyperplasia without atypia, all those cases will directly go to the gynecologist. Unless and until there's, so out of 70 cases that I screen there, I will only get around 5 cases. Rest, everything goes to the gynecology department because it's benign.
And
Thank you,
many
ma'am.
times, ma'am, secretory endometrium, like thickness will be increased even in secretory endometrium.
Yeah.
So, like they will say, no, it is like endometrial thickness is increased. That time also, it's, what is your takes around that? Like secretory endometrium thickness will be increased, and we'll say, no, there is no malignancy. So, how you deal with the such cases, sir?
No, you have to talk to the
Postmenopausal,
clinician.
huh,
Yeah, you have to
very-
talk to the clinician. You have to take a thorough history, and sometimes what happens is the patient comes to the referral center, but they would have visited other local gynecologists and they would have taken pills also. So that is another scenario which we have to discuss with the clinician whether there was pill endometrium, because even in pill
Yes, sir,
endometrium, the
pill.
endometrium is thickened and
Thickness,
they may give history of passage of clots. So the clinical suspicion of malignancy will be high, but histopathologically will be not seeing any evidence of malignancy. So this again we have to discuss with the clinician, discuss with them, ask the history, and discuss with the radiologist or the gynecologist if they have done a TVS or a TAS, and then finalize the report, ma'am.
Yes, thanks.
Thank you, ma'am. Now I request the chairpersons to kindly present a certificate of participation to the guest speakers.
First, we have to introduce, no? I will introduce the Dr. Pradeep Gaudar. I am Dr. M. Patil, senior radiologist. Dr. Pradeep S. Gaudar is a consultant radiologist with over 10 years of experience, and currently he serves as associate professor in the Department of Radiodiagnosis at KLE Dr. Prabhakar Kore Hospital, Belagavi. His areas of interest include oncological, thoracic, fetal, imaging, and non-vascular interventions with multiple publications in the national and international journals. I thank Dr. Pradeep S. Gaudar for enlightening us the ovarian carcinoma and also endometrial carcinoma, different MRI features. It was a nice.
So it's my privilege to introduce Dr. Adarsh Sanib sir. He is an experienced oncopathologist and associate professor at JNMC KLE. He has completed his UICC fellowship from Tata Memorial Hospital, Mumbai, and fellowship in oncopathology from Kidwai Hospital. He has set up many ISC laboratories, flow cytometry and frozen section. And he has presented many oral papers in the international and national CMEs and actively involved in the validation of fish, ISC, and cytology and flow cytometry. So it was a wonderful interaction, sir. Thank you.
Now I request the chairpersons to kindly present certificate of participation to the guest speakers.
The chairpersons will now receive the certificates from Dr. Ravi Kattimani, Associate Professor, and Dr. Nidhi Ma'am, Senior Resident, Department of General Medicine.